Good day, everyone. This is Shirley Marisi Bacos, your student nurse from the Visayas State University, and today I will be tackling about urticaria, angioneurotic edema, and hereditary angioedema. So, what are the differences between the three allergic disorders? So, first, we will tackle about urticaria. So urticaria is also known as hives. It is a type 1 hypersensitive allergic reaction of the skin, and it is characterized by edematous, pink or red wheals of variable size from 2 to 4 millimeters, and this is also characterized with general pruritus. So as you can see in the picture, these are wheals. And later on, as we go on through with our lecture, I will be showing to you the difference between a wheal, a pruritus, and as well as a localized edema, or erythema rather. So urticaria is most commonly instigated by infection, allergic reaction to food such as peanuts or fish or any type of food, insect stings, and medication. Um, For allergic reaction, this could also include physical stimuli or physical factors such as water or heat or anything. Each hives may remain for a few minutes to several hours before disappearing. Now, the pathophysiology of urticaria is that it can be classified as an immunologic urticaria or non-immunologic urticaria. So as for immunologic urticaria, which is IgA independent, an antibody, it is a type 1 hypersensitive sensitivity reaction, which leads the allergen binds to the IgA receptors on mast cells or basophil surface. This will then lead to activation and degranulation of mast cells, which causes the inflammatory response to start. Hence the occurrence of wheals, the reddening of the skin, also known as erythema, or it can also be in some cases warm to touch for the skin. As for non-immunologic urticaria or non-IgE dependent, this can be caused for four etiologies, which can be through activation of membrane receptors involved in innate immunity, direct toxin stimulation, emotional stressors, physical stimuli, which was mentioned earlier. Aquagenic, it could be aquagenic in nature, solar, which can be caused by UV visible lights, and it can also be cholinergic. These etiologies will then lead to the activation of specific receptors without previous sensitization, and leading to the activation and degranulation of mast cells, thus starting the inflammatory response, causing the clinical manifestation of urticaria. Now, I will further discuss from activation. This can lead to three different paths, which could be binding of H1 receptors in smooth muscle cells, endothelial cells, and CNS neurons, which will then start up the triple response of Lewis, which is vasodilation, vasopermeability, axon reflex in CNS. This will then lead to local erythema, wheal, and pruritus. Another would be there will be a binding of H1 and H4 receptors on peripheral nerve fibers, and another would be binding of H2 receptors leading to local erythema. Okay, as mentioned earlier, this is the difference between a wheal, pruritus, and an erythema. We have here a wheal, the pruritus, the details of pruritus, and a localized erythema. So the diagnostic procedures for urticaria is that the patient should undergo a complete blood count with differentials, erythrocyte or sedimentation rate, and C-reactive protein. So if the patient has urticaria, it should be expected that the serum tryptase is elevated and as well as the IgE levels is elevated. In other cases, there is another way of diagnosing urticaria. which is named as the challenge testing. This is to diagnose the specific allergen that is causing the urticaria. So one is exercise challenge, ice cube challenge, heat challenge, and pressure challenge. The therapeutic management for urticaria is that as a nurse, you should prioritize that you have eliminated the causative drug or food for the presence of urticaria. You should avoid the use of NSAIDs or non-steroidal anti-inflammatory drugs and minimize potential aggravators including heat, stress, alcohol, and tight clothes. Lastly, it should be your responsibility to administer antihistamines as prescribed and possibly a short course of corticosteroids. Now we will be moving on to angioneurotic edema and hereditary angioedema. What is the difference between the two? Now, angioneurotic edema, also known as angioedema, involves the deepest layers of the skin, resulting in a more diffuse swelling rather than the discrete lesions characterized of hives. The regions most often involved in angioedema are the lips, eyelids, cheeks, hands, feet, genitalia, and the tongue. Now later on, I will be showing you pictures as to what angioedema really looks like. Hereditary angioedema, on the other hand, is a rare, potentially life-threatening autosomal dominant disorder. It is not commonly characterized by itching and usually is not accompanied by urticaria, unlike angioedema. Attacks may last 2 to 4 days, and the regions most often involved is the mucous membranes of the larynx, bronchi, and gastrointestinal canal, which is the reason why it is potentially life-threatening. Now, this is how angioedema looks like: the eyes, the cheeks, and the lips. Now, the pathophysiology. Let's start for angioneurotic edema. There are four etiologies for the occurrence of angioneurotic edema or angioedema. This can be caused by mast cells degranulation or activation of the kallikrein-kinin cascade, IgE-mediated hypersensitivity, which may cause allergic reaction, chronic urticaria, and in some cases, it can be idiopathic. Now, these etiologies will lead to increased permeability of the submucosal or submucosa capillaries, which will then lead to localized plasma extravacation, leading to swelling, and then thus the occurrence of angioneurotic edema. Now, the clinical manifestations for angioneurotic edema is that there will be non-pruritic brownie, non-pitting edema, and erythema. As for hereditary angioedema, the very cause of hereditary angioedema is that there is a C1 INH depletion, and there is a presence of IgG antibody directed to C1 INH, causing the depletion. Now, these will then lead to two effects. There will be an increased production of vasoactive nonapeptide bradykinin, causing the edema and angioedema rather. And then another would be is that there will be an abnormal increase in activation of C1, leading to consumption of C2 and C4, and decreased plasma levels of protein, leading to hereditary angioedema. This will then later on manifest as an edema of the skin, in some cases the respiratory tract, which is very fatal if not managed in that note, and in the GI tract. Now, the diagnostic procedure for angioneurotic edema is that there will be blood tests. This is to see for presence of antibodies reacting to an allergen, and as for the case of hereditary angioedema, the blood test would then reveal if there is a level of C1 esterase inhibitor or C1 INH, if there is. And as for hereditary angioedema, in the blood test, it would be checked for the level of C1 esterase inhibitor Another test would be the skin prick test, to which in this test, the skin is pricked with a tiny amount of the suspected allergen to observe a reaction. And lastly, the therapeutic management for angioedema and hereditary angioedema is that in worst cases, if the edema does not subside, tracheostomy would be then performed. So it is a very important nursing management that you would monitor your patient for any signs of obstruction. And lastly, you would administer epinephrine and antihistamine and corticosteroids as prescribed. So that would be the end of my session. I hope you've learned something, and thank you for listening.